Assalamu alaikum wa rahmatullahi wa barakatuh. I myself is one of the patients who underwent surgical fixation of the neck, not secondary to rheumatoid arthritis, but secondary to RTA or NVA, depends on which country you graduated from. I'll give a synopsis of some of the rheumatological brackets, orthopedic complication in the spine, mainly the cervical spine. Basically, cervical pain is very common, or as common as low back pain, although less time off work, because patients or individual can go and work even with the presence of the pain. Less so is the neurological complication of cervical pain. This is some of the rheumatological, and I said put them in between brackets. The more common ones we see even in rheumatology, not only orthopedics clinics, are the cervical spondylosis. Fibromyalgia is very common in this country, and sprains and strains of the muscles and tendons around the neck. Dish and rheumatoid arthritis is basically rheumatoid arthritis is one of our diseases, and I'll talk a bit longer on that. And also spondyloarthritis, mainly ankylosing spondylitis, and some of the more rarer entities. Cervical spondylosis, common, degenerative, gives you pains in the neck, shoulders, may gives you also some neurological complications. The treatment is usually conservative, and if it gets more advanced and progressive, then it may go into surgery. The one which is more rheumatological based entity is this fibromyalgia, which used to be not so common in this country, but nowadays we see half of our clinics are about this, and they're usually mostly women. Initially, when I was training 20 or so years ago somewhere abroad, they say you don't see fibromyalgia. At that time we didn't, but nowadays with the basically adoption of more Western lifestyle, we see a lot of these. So basically, according to the American College of Rheumatology criteria, it's a chronic widespread pain in all four quadrants of the body. And you get 11 of 18. There are about 18 here, and some of them, if you count them there, go up to 22. But 11 of 18 tender points with a pressure of about 4 kilograms of pressure. And you should not just get tenderness, they report it as pain. And allodynia. Allodynia is basically tenderness in response to normally non-painful stimuli. So it's usually we get tenderness, but not so much pain. So they basically a pain magnification syndrome in these individuals. They do not only get pain, but they also get symptoms, numbness. Sometimes they report weakness, hotness, coldness, all of these symptoms. But clinical examination does not bear any of these symptoms out to be of objective finding. As we said, it's usually more common among women, and the treatment is non-steroidal. Used to be Flexeril and amitriptyline, gabapentin. Now we have pregabalin, which is Lyrica, but all of the other ones basically, which are used in psychiatry also, we use in lower doses in this condition with some good results. This one, pregabalin, milnacipran, and also duloxetine are approved in the US for this treatment. Dish, as known to the orthopedics, and I'm sure to you, is basically a degenerative spine disease with criteria set, basically calcification along the anterolateral aspects of at least 4 cardiac vertebrae, with preservation of the disc height and also absence, because the differential diagnosis here is ankylosing spondylitis, the absence of any changes around the sacroiliac joints and also apophyseal joints. And may be asymptomatic, but you may get also pain and stiffness and loss of mobility. And some of them may even cause dysphagia and airway obstruction. The next one, which we would deal with more in this rheumatological practice, in addition to fibromyalgia, is rheumatoid arthritis. And there are sets of criteria initially proposed by the American College of Rheumatology, and then later on, last year, they were altered with the cooperation of the EULAR, which is European League Against Rheumatism. And they set a more complicated criteria, which we will not go into, but basically rheumatoid arthritis is an inflammatory disorder with the target being the synovial membrane of the synovial joints. Why it happens? Because like most of the autoimmune diseases, there is some genetic predisposition from the individual, in addition to some environmental agent which comes from outside. This is basically summarized in this. So there is environmental and genetics. They activate the immune system, which later on also go from the innate immunity to the adaptive immunity, with the target being, with the antigen being presented to the T cells. The T cells and also dendritic cells, macrophages, fibrocyte-like synovicyte, they all participate in the destructive processes. And later on, they basically encourage the osteoclast to eat away at the bone. Lots of cytokines are produced in this process, as basically summarized by this. We do not need to go into them, but to know that there are so many of them, and more are being discovered each day. This is a normal synovial membrane. The thickness is only about 1 to 3 cells thickness, which goes and multiply to this thick synovial membrane, and also development of new blood vessels, lymphoid follicles, accumulation of inflammatory cells. Involvement of cervical spine is common according to the literature, although we do not see much of it in this place. Maybe our rheumatoid is less severe than what they encountered elsewhere. Maybe our records do not go as far as back as they do. But even in the United States, there has been basically decline in the procedures done to fix the cervical spines in recent years. Despite that, the admissions did not drop from 1983 to 2001, but the rate of operation has dropped during those years. It's reported to affect about 17 to 88%, but that's a wide gap, depends on who is the researcher and what study, what methodology, etc. Neurological complications even have a wider gap, from 11 to 70%. I must say we do not have that much here. We do not have much complication. We have a lot of rheumatoid, but we do not encounter a lot of cervical radiculopathy or myelopathy secondary to rheumatoid. It's said to be, to be associated with more severe disease, like we get with all of the other diseases. But the more seropositive rheumatoid nodules, rheumatoid factors, more peripheral joint disease, you will expect severe diseases elsewhere. Why cervical? Because there are lots of synovial joints, no protective intervertebral discs, and even the ligaments between the dens and transverse ligament is also lined by synovial tissue. How to prevent it? And maybe this is why we do not see rheumatoid, because we are recent at the treatment of rheumatoid arthritis. So we tend to treat early with combination therapy, as in this study which showed that reduction of cervical complication if you treat them early with combination therapy versus single therapy. In this study, the combination of psilocybin, methotrexate, hydroxychloroquine, and prednisolone versus psilocybin reduced the incidence of atlantoaxial impaction or subluxation to 0 in the combination, while it was 2 to 7 in the single therapy alone. At 5 years follow-up, after they basically gave all of them combination, also still those who started with a single therapy had more complication. That was part of the treatment, because it wasn't really done on the more advanced treatment we have now. We have more advanced treatment, more categorization of ways of treating rheumatoid. So now basically you categorize rheumatoid into mild and moderate to severe. The mild, you give the lesser disease modifying agents such as hydroxychloroquine, psilocybin, while the more severe and moderate, you start with a stronger drug like methotrexate. You add also prednisolone, some of them, and you also consider adding anti-TNF agents or abatacept or rituximab, which are the new generation of drugs which are more effective than the old generation of drug to suppression inflammation. The second disease we will talk about is basically spondyloarthropathy, and mainly ankylosing spondylitis. Ankylosing spondylitis affects mostly the sacroiliac joints and also the spine from the top till the end. And what happens, it basically bridges the spine and makes it less mobile, less pliable. It actually calcifies the anterior segments and also even ossify the posterior parts of it. Usually it's a disease of the males, more common in men. Onset is early and likely to begin after 45. And usually with a delayed diagnosis. And there is a strong correlation with HLA-B27. And that strong correlation is apparent in the incidence worldwide. Like the high end of the coast of Western Canada have a high incidence of ankylosing spondylitis because they have also a high incidence of HLA-B27. The other parts are less so. In here we have lower incidence because our HLA-B27 is only 1.3. We actually only accumulated a few cases, that's about 15 years ago, in 5 years because of this low incidence. We do not see a lot of ankylosing spondylitis unless there is related patient's marriage. The diagnosis is basically based on a 1984 modified New York criteria, and basically they have clinical and the radiological, but you have to have the radiological for a definite diagnosis, and they are basically listed here. This is what we call grade 1 on the left and grade 2 on the right, grade 3 here, and grade 4 is basically total ankylosis. Notice that the spine does not come in the initial diagnostic criteria. If it's still early, then we do the MRI, which shows basically bone marrow edema and sometimes erosions. The spine is affected later on, and usually like this in the cervical spine, in the lumbar spine. And they basically give you at the end the bamboo spine. The complication of this is basically because this is ossified and the movement is restricted and stiff spine. What you get with complication is the spinal fracture, mostly in the cervical spine, and maybe missed by the patient and also missed by radiological investigation because the spine anatomy has been altered And so you need basically MRI and CT scan to detect some of these fractures. The Coda equina syndrome may also happen, and you need MRI. It's a surgical emergency to prevent lasting neurological damage. The treatment of ankylosing spondylitis, as an example of spondyloarthropathy, basically, initially, educational physical therapy rehabilitation. Non-steroidal is effective, and it's one measure of also making a diagnosis of back pain response to non-steroidal. It's most likely to be the inflammatory nature of ankylosing spondylitis rather than the orthopedic variety back pains with degeneration. Second line, if you have sulfasalazine, usually in the peripheral joints, but in the central joints now, the consensus is that anti-TNF is needed. That meaning that if you have a back and spine disease, you need to go straight away to anti-TNF. There are some studies which may suggest this to be helpful, but they are weak. This is basically a summary of the therapy for it. MTX and non-steroidal, we said. Steroid is usually not effective. Methotrexate, limited, but usually peripheral, not used in central, which is spine. Celazopirin, limited effective, but we need to go to the etanercept, infliximab, adalimumab for a better treatment of spinal diseases. Does it arrest the ossification? No. It reduces the inflammation, but the ossification goes on. So it does not, and some will say if you start it later on, then it may even speed up the ossification process. So now the drive is basically to start this anti-TNF very early in the therapy. Bits and pieces, gout has been reported to be deposited in around the spine and produce fractures and myelopathy. They're usually treated with surgically and also with medical therapy. There have been even reports of lower cranial nerve involvement by deposition of tophi. CPBD, which is calcium pyrophosphate dehydrogenase, has been also seen around the spine, causing either neurological symptoms or sometimes just local symptoms. And the X-ray, the plain X-ray may not reveal it, but the CT examination may reveal the linear deposits, transverse ligaments of the atlas with the crown dense syndrome. Hydroxyapatite is another crystal which may deposit around there, but it's not so common. The last slide is basically the cervical spine and juvenile chronic arthritis, and it may be affected similarly to the other adult type and also ankylosing spondylitis, but much less frequently. And also psoriatic arthritis, being part of the spondyloarthropathy syndrome, may be affected, but less than ankylosing spondylitis. Thank you.